right. So, thanks, Randy, for having me.
Anytime. I love this.
Yeah, the title of the talk today is Protecting Generations, a Community Response to Congenital Syphilis in Tribal Communities. And I think that, like, throughout the presentation, syphilis in and of itself is a huge issue. And we have to make sure to take care of syphilis, but really focusing in a little bit more today, to go beyond Dr. Mara's presentation earlier in the series, to talk a little bit more about congenital syphilis and sort of kind of where it sits and what it means for our communities. So we'll talk about just syphilis holistically. We'll understand some of the current epidemiology, and then also the other contextual stuff that's really important. And then go through the symptoms, the screening, the treatment, what it is we're trying to prevent, and then discuss some ways in which to engage relatives and clients in the work that you do, whether it's like as a community health professional or a nurse or whomever you are, your professional role in the community. So I know that I don't need to tell you this, Randy, but syphilis is caused by a bacteria. It has to be treated. It will not go away by itself, even if the symptoms go away. Sometimes people don't know that they have symptoms. They don't see or feel it. Other times, symptoms look like common issues like pimples or rashes. Syphilis symptoms can even come and go over time, making it seem like whatever was there, it then cleared up on its own. And one reason why syphilis is so sneaky is that the symptoms do come in those stages. We'll review more of that on the next slide, like what one of the manifestations of it are. But the other thing is that in each state, it's going to look different for different people. Like it is not going to present the same way on everyone. Like for instance, like even changes in vision are a less well-known symptom of syphilis. Even in early stage syphilis, eye and vision problems can occur. And then, like I said, we're going to be talking a little bit more about congenital syphilis today, which is when syphilis is spread through the placenta from a mother to her unborn baby. And while we care again about and we want to treat all syphilis, congenital syphilis is uniquely devastating because it can result in permanent and lifelong disability and also pre and postnatal deaths. So this data here from 2019 to 2023, and it shows American Indian, Alaska Native people on the top, and you see the general increase. One of the reasons why we're using the slide is just because it fits better in the presentation. But if you go back from 1940s, even if you go back to early 2000s, you will see like the real drastic uptick in syphilis that has occurred in the past 6 to 7 years. This graph, even though you see the increases, is really just like the tip of the increase as it was happening from 2019 to 2023. The slide shows a lot of what we see all the time, in that American Indian, Alaska Native, Black African American, Native Hawaiian and Pacific Islanders really have a disproportionate effect of syphilis in the community. And then Ashley was nice enough to drum up this slide really quick. Thank you, Ashley. But it shows specifically California rates from 2017 to 2023. And in California, the top two are flipped, a Black and African American at 37%, American Indian, Alaska Native, not percent, I'm sorry, 37. Per one, is this per 110,000?
Yeah,
10,000
100,000.
per 100,000, American Indian Alaska Native at 25, and then so on and so forth. So it goes down. I was talking, we were talking, Ashley and I, a little bit about we don't know what racial misclassification looks like in California, but I would assume a lot of people are racially misclassified in a lot of places. So there is a high likelihood that American Indian, Alaska Native are actually much higher. And this is what the primary and syphilis rates look like by county in the United States. And you can sort of see California over there, and I have a better California only slide. But this to show a lot of those dark blue areas. First of all, the fact that the dark blue goes from 20 to 1,100 per 100,000 is a little drastic. I feel like they need to add in another color there. But also you see that that dark blue overlaps with a lot of Indian country, a lot of American Indian, Alaska Native tribal lands, whether they be reservations or rancherias or just other places as well. Oh, we have another slide in here. That's okay. So if you look at primary and secondary syphilis, broken down, male versus female, you see the differences even more greater between American Indian, Alaska Native females and let's just say whites. It's 10 times the rate of white versus American Indian, Alaska Native for females. It's 5 times the rate for males. And this is concerning specifically because we want to protect our females, but also because when rates of syphilis go up in females, the rates of congenital syphilis are going to go up as well. And you see that for sure for rates of reported case by race and ethnicity from 2019 to 2023. American Indian, Alaska Native way up there at 600 and I think maybe like 50 or so per 100,000, and just so much higher than any other race or ethnicity. And this is what it looks like in California. They don't break out American Indian, Alaska Native in California because they say the number is too low, which I would want to find out more about. But the rate is just generally higher in California versus the US in general. So higher rates of syphilis in California. And then you're also able, I'm just going to flip to congenital syphilis by counties in California. So you can see a little bit more where the higher cases are of congenital syphilis in California, if it is where you are, cases versus rates. And really, you should look at rates because that takes into account the density of the population in that space. And then here are like just the top counties and how they overlap with where tribes are located in the state as well. And then the last thing that also comes into this so much for congenital syphilis are the disparities in American Indian and Alaska Native infant and maternal health. Just generally, nearly 27% of all Native babies were born in areas of limited or no access to maternity care. They have American Indian Alaska Native people have 2 times higher pregnancy-related mortality rates compared to white women. And nearly 40% of pregnant women who use substances did not receive prenatal care. And this is just really important because we know so much of congenital syphilis is tied up into other syndemic issues, including substance use disorder as well. And then you have the maternal mortality rates from the CDC MMWR below, and you'll have this presentation so you can look that up if you'd like. But it's more than the numbers. And I always like to share this story from Tiffany, and let this piece of data also like explain some of the larger systemic issues and holistic drivers or systemic drivers that are impacting congenital syphilis. So 17-year-old Tiffany presented to the emergency department in October of 2022 with with urinary tract symptoms. So she went in because she thought she had a UTI. She tested positive for a UTI, and she also tested positive for a pregnancy. The ER performed an ultrasound and found out that she was 14 weeks pregnant. She was treated for her urinary tract infection, and at that visit, the ER drew prenatal labs, and she was also referred to the prenatal clinic. So already in this place where Tiffany is, she has some things working for her. The clinic actually had an ER. They had OB on staff so that they had prenatal clinics like routinely in this place. So that's where Tiffany's story starts. Tiffany's prenatal labs came back. She was positive for syphilis and for chlamydia. All other labs, pregnancy related and STI related, came back fine for Tiffany. So no other problems. She just had syphilis and chlamydia. The local public health nurse really tried really hard to reach Tiffany via phone, but couldn't get into contact with her, which is like true so many times in communities. Their phone ran out of minutes, or where they were staying isn't where they're staying anymore, or they couldn't pay their bill, or they just got a new phone, who knows, many reasons, but they could not get in touch with her. Tiffany was finally able to make it back to the clinic in December of 2022. So that's 4 months later, she was finally able to make it back to the clinic, never having had any kind of prenatal care. And also not being treated for her syphilis. She had a rash at that time, but she reported that she was no longer with her partner, so she declined to name him. So at that visit, Tiffany was treated for syphilis and chlamydia. She had the rash on her hand, so they were able to appropriately stage the syphilis and everything. And then again, prenatal care and an ultrasound was arranged. In late January, after several missed visits, again, Tiffany returned for an ultrasound and a visit. The labs from the second visit indicated that she was positive for syphilis and chlamydia. So I'm just gonna, I can't see people. So is there any, Randy? So what happened, or anyone else that's joined us since the beginning? So, you know, she was treated for syphilis. She was staged, and per her stage, she should have only needed one shot of penicillin. So what happened?
I mean, she probably, it's, I mean, I don't know, maybe she got it again, or
Mhm.
maybe, you know what I mean? Like
Yeah.
she probably was still engaging in whatever kind of, you know, activity. Maybe she got back with with the guy that she, who knows?
Yes.
So she
And
just
that's
got it
exactly
again.
what happened. Yes. And that is exactly what happened. In early March, after extensive outreach efforts and missed visits, the superhero PHN located Tiffany at a site that was associated with meth use. She had reunited with her partner, and her partner was never treated. So even though she was treated for syphilis and shouldn't have syphilis anymore because she was back with her partner, she got syphilis again. So thankfully, the PHN at that site had treatment on hand and was able to draw labs. So that day, Tiffany and Marcus both received treatment for syphilis and chlamydia, and which was really great. And then they were able to draw more labs. Follow-up was arranged for prenatal care for Tiffany, and syphilis staging for Marcus, so that, you know, there still needed to be some more work that to be done. Despite extensive outreach efforts, Tiffany was not seen again until early April in labor and delivery. She was almost 37 weeks pregnant. She had blood pressure. She had high blood pressure and displayed characteristics of intoxication when she came in labor. And then a urine drug screen for methamphetamine was confirmed. She progressed rapidly in labor and delivered a 5-pound, 14-ounce baby who was not doing very well at all. Tiffany's baby was transferred to a NICU close by, and treated for congenital syphilis for 10 days. They were subsequently lost to follow-up. The family did say that Tiffany had left the state for a sober living home. So there's so much, when you look at the data in a bar chart or a graph, it's so different because every single person in one of those graphs or in one of those bar charts is a Tiffany. It is a person who has a story, and, just like syphilis that presents differently, like each of those data points presents a different story. But at the end of the day, every single time a congenital syphilis case happens, it presents huge gaps in care. So many places probably for increased systems care and connection. So there's so many things that could have been done for Tiffany. Does anyone so I don't know if everybody was on for the whole story, but what could have changed in this story to make sure that, Tiffany was able to get the care that she needed, from a community health perspective?
I mean, I would have assessed like what transportation barriers she would have had, um, you know, phone barriers, maybe an emergency contact, a family member or friend that like, we could try and get a hold of instead of if we couldn't get a hold of Tiffany.
Mm-hmm.
I definitely would. I mean, I'm assuming that a ton of education was provided through the prenatal care clinic, but just the you know, what happens if you don't treat congenital syphilis.
Mm-hmm.
I don't know how much that would have changed considering she tested positive for meth when she came in, uh, for to deliver. But I think that's all. I mean, you can never educate too much. So yeah, I don't
Yeah.
know.
Yeah, I think that those are really important, especially considering, because we don't know what education was provided. We don't know if it was in a way in which Tiffany was able to receive it. Also have no idea what her ability was to get to and from the clinic was. When the public health nurse did go out, they were able to find her. Is there anything else does anyone else want to offer anything? The other things that I think about are, was she ever screened for substance use disorder? Did anyone ever ask her about that? When you're talking about the syndemics overlapping, potentially that was another place to provide wraparound care. And again, like what was Tiffany dealing with? Like, was she able to get to clinic? Did she have transportation? Was she too active in her substance use disorder to make certain decisions to get her someplace? There's so many things from Tiffany's point of view that are, hard for people working in public health and clinicians sometimes to stop and to consider truly like what it takes for someone to walk in the doors to a clinic each time they make a clinic appointment.
Well,
Um,
and even I was thinking like maybe the clinic that because she went into the ER and just was kind of assigned that clinic. And
mhm.
so maybe, again, back to like transportation, but maybe there's something closer to where she lives or where she's staying that might have, could have been an option. Uh, yeah, I mean, I don't know. I just feel like you have to really kind of dig when you talk to clients and patients. You kind of have to really dig. You have to be an investigator and kind of
Yeah,
like really figure out like, okay, so is this going to be a barrier? Because this is, important stuff. So yeah,
yeah.
again, just exactly what you were saying.
Yeah, no, thanks, Randy. I think, if we're talking about health equity, and the disparities specifically in American Indian, Alaska Native people with congenital syphilis, we have to think about equity. And when we think about equity, we have to acknowledge and be okay with some people need more in order to get the same thing. So some clients need more help from the health system in order to achieve the same health that someone else is going to achieve with no help at all. And that's what equity is. And it's understanding that we need to do that for our families, for our community, if we want to achieve better health. Because then all of a sudden, if you're giving people a little extra help, maybe one day they don't need that help anymore. Maybe they do, and that is okay. But we're just trying to lift people up and bring them to different health spaces. And that's the idea between, I'm sorry, my allergies are like really bad today. My nose is so itchy. And that's the idea too, with like looking at things from this this indigenous determinants of health lens, really looking at health not from a very Western biomedical space where you have syphilis. Syphilis looks like this spirochete. We're going to treat you for syphilis and then you'll be done. Like that isn't working right now, right? Like that, because it's not just about the spirochete. It's about everything else that affects a person's health. And this graphic was made in collaboration with Alicia Edwards, who's online from Turtle Island Media Group. But we have to look at health from a structural and systems lens and understand and really understand and let it be part of the health system itself, that political and socioeconomic context is important. Land removal is important. Treaties are important. Culture is important. Socioeconomic position and where a person is financially and whether they have a job is important to their health. The health system itself is obviously important. The fact that the Indian Health Service and thus tribal and urban facilities are funded at like 40% of need. Like there's no other system that you would, give 40% effort to and expect it to achieve 100% outcomes, And so there's all of this structural stuff that actually encircles mental health, emotional health, physical health, and spiritual health that then encircles community health, the health of our ancestors, the health of our community, of our family, and of future generations. And like, I think until we really embody this as a health system, as clinicians, as community health professionals, and like start to take action in it, to like even Randy, like what you said, like acknowledging, where a person is, like what are their transportation needs. Maybe they can't come to clinic. So this person needed a mobile prenatal clinic, in order to achieve prenatal care. Like these are the questions and considerations that are around indigenous determinants of health. And I'm just gonna skip this part for time's sake, but it'll be in the PowerPoints that you get. So what can we do as community health professionals? I think generally, no matter if we're talking about syphilis or congenital syphilis or HIV or diabetes, we can learn about it ourselves and be educators of ourselves so that we can be educators of our community. We can address stigma and develop solutions that fit your community. So syphilis is easily spread. So the education part, right? Syphilis is easily spread through vaginal, anal, and oral sex, and even sometimes through mutual masturbation. If someone finds out that they have syphilis, they can also protect themselves and their partner by talking openly about infection and waiting to have sex until the treatment is complete. So all sex partners have to be tested and treated for syphilis, maybe not even tested, just treated for syphilis before they have sex with each other again, or else, the cycle can continue. Because it's possible to be reinfected if one of the sex partners has not been treated and not been cured. To reduce exposure to syphilis, people can also abstain from sex if that is a viable option for them. But most people choose to have sex at some point in their lives. So using a condom correctly every single time or practicing mutual monogamy will help lower the risk of spreading syphilis and any other STI as well. Oops. So it's caused by a bacteria, just as a brief overview. It must be treated. It won't go away by itself, even if the symptoms go away. There are different stages of syphilis. It's sneaky, like we talked in the first slide. It can present as many different things or none of the things, and it's different for every single person. And like on that first slide, I said, it can cause vision problems, ear problems, and at any stage of the disease. So it doesn't have to occur in any one stage. So when I'm talking stages, which I probably should have done first. So there's a primary stage of syphilis. What are the symptoms? Round, painless sores that we call chancres at the site where syphilis enters the body. So it's going to be in places where the syphilis is in contact with. The sore can be around the vagina, the penis, the anus, the lips, or the mouth. I've had clinicians even tell me that they've seen a syphilis chancre on someone's forehead. The sore may be open and it may be oozing. It will go away generally in 3 to 6 weeks. But the person will still be infected with syphilis. That chancre or sore is very contagious. So if that chancre comes into contact with another open space, there's a very good likelihood that the other person will get syphilis. And you might be saying that, well, why wouldn't you would see this, you would feel it, you would know, but really, truly, sometimes if it's like inside the vagina or in a weird location, because it can be painless, you really might not notice that you have it. And then secondary stage of syphilis. The symptoms of secondary stage are rashes on the palms or the bottom of the feet, sometimes on the trunk, like the chest or the back. You can have a slight fever, swollen lymph glands, other just general malaise, like feeling not well and sick. They can actually overlap with the chancres, the secondary syphilis stage. So the chancre does not have to go away in order for the secondary stage to start happening. And secondary stage can actually come and go over a few years. So there's no like, this is how long you'll be in secondary stage. And then there's considered latent stage. In latent stage, most people have no symptoms for years, even as damage is occurring inside the body. You will not feel it in this latent stage when it kind of goes to sleep outwardly. And then there's also tertiary syphilis. It doesn't affect everyone, but it can cause severe damage to different organ systems. And the symptoms really depend on what organ system the syphilis in this stage, this tertiary stage, is affecting. And then there's also syphilis during pregnancy, which can cause serious health problems. Untreated syphilis during pregnancy can cause miscarriage, stillbirth, and premature birth. When a baby is infected with syphilis during pregnancy, that is when we call it congenital syphilis. When the baby is born, they can develop problems in the brain and in the nervous system, blindness, hearing problems, bone and teeth deformities, and the baby may also die before or shortly after being born. And as we saw with the data slides earlier, we know that congenital syphilis cases are rising in the US and in California, which has higher rates than the US rates. And that's why it's so important to just generally being tested for syphilis, like as part of a routine STI panel, but also especially 3 times while you're pregnant. So health issues with untreated syphilis for adults can be blindness, hearing loss, and nervous system issues that can happen. syphilis can cause dementia. It can cause paralysis. So it can affect the brain and other nervous system and other organs. So in tertiary syphilis, like things get bad, right? Like it's affecting your organs and things get bad. If someone gets treatment late, they can still be cured, and it's going to stop further damage probably from happening to the body, but the damage already caused by syphilis will usually not be cured or changed. Okay, that was all, that's a lot, right? There's like really bad syphilis, get tested, get treated early on in the infection. Also because, syphilis is infectious in the early stages. But screening and testing and treatment is relatively simple. It's just simple blood tests, whether it's like in a clinic or there's a lot of CHRs or public health nurses that'll go out into the field and do testing in the field as well. Sometimes the sample is taken from like the sore or the chancre, but not usually. It's mostly this blood tests. There's tests that can be sent away and tests that can happen really rapidly, just like rapid HIV tests. And then it's really simple. It's just cured with antibiotics. It's cured with penicillin. There's like a caveat with that we might want to talk about at the end of the presentation, but it's cured with penicillin. Just the things to note that all sex partners should be tested and treated, and that there should be no sex happening until treatment is completed by the patient and all of their partners. So it's quiz time. What did you learn about syphilis? A, it's easy to tell a syphilis chancre from other sores. B, when syphilis is cured, the damage done to the body will fix itself. Or C, testing is simple and is the only way to know for sure if you have it. Now, don't everybody speak at once.
I mean, I'm confident in C.
Yes, you would be correct, Randy. You would be correct in your confidence. Yes, testing is simple and it's the only way to know for sure that you have it. Okay, so like moving on, then what can we do? So we learn more about syphilis, and then we also address stigma. And I think, in addressing stigma, we can address stigma for syphilis and congenital syphilis and for substance use disorder and pregnancy, and so many other reasons that people feel stigma. So these are they're kind of like snapshots of different flyers that we have for clinic. So when we send out the PowerPoint, we can include these flyers as well for you to take a look at, maybe share with your clinic. But really, they're getting at that sexual health stigma can take many forms. Sometimes people with STIs can be perceived as bad or dirty, and that's both by individuals and by clinic staff as well. It can also be stigma against Two-Spirit and LGBTQ plus individuals. It can be around sexual dysfunction and just general sexual health. It can be stigma around, abortion. It can be a lot of different things. Stigma can also make it really difficult for pregnant women and mothers with substance use disorder to get adequate health care because of all of the things that they feel when they are pregnant and active in their substance use. At the end of the day, the important thing is that we have to address stigma and make open spaces. We have to address stigma by asking ourselves what our own biases are and kind of unpacking that and understanding where we sit with everything to hopefully be better for clients. And then also address stigma that you hear from other people in an open and curious way. And having more conversations about that. And at the larger community level as well. Because what we don't want is is for a pregnant person who wants to come in to get care for her syphilis, or who wants to come in and get care for their substance use disorder. We don't want them to feel any deterrent from coming in. We want them to know that when they present to clinic, they're going to be accepted, not judged, and helped. And helped when they come in. Some stigma against pregnant women and mothers and substance use disorders can take a lot of different forms. And this is where we really see the biggest stigma, especially with congenital syphilis. There's a lot of misinformation happening. There is punishment of substance use instead of like helping people with substance use. We've even seen, we've seen tribes that for various reasons, if a pregnant person was using substances, they will put that pregnant person in jail. They won't try to help that pregnant person, but they'll put them in jail instead. Or belittling, they'll belittle a mother's relationship with her child. In your substance use disorder, there's so many like misfirings that are happening. And just because a person is pregnant and using substances doesn't mean that that person doesn't care for their child and their baby. They just have a lot of different things going on. And like we said before, they need a little bit of extra help. And so like what you see from this judgment is people who face stigma, distance themselves from other people, from their community, from their family, and also from the health system itself. So that's why we have to, really start unpacking stigma in different ways in community conversations, in the health clinic, because we don't want that social distancing, especially around congenital syphilis and pregnant people right now. And then lastly, what can we do? We can develop solutions that fit your community. So some of these things include patient communication while protecting confidentiality. There's some clinics that are using community health professionals, community health representatives, to do some help with contact tracing, or bringing in people who have syphilis for treatment. And they're kind of helping find people with syphilis, because a lot of community health professionals are from the community and they just generally know what's going on. You can help get information to patients who test positive but may not know the test results. Help patients with ability and willingness to access treatment, like locating patients, transporting the patient to the health facility, working with the public health nurses, navigating care systems, and just general care navigation. And also they can help with patient incentives, and making sure that if you're coming in for syphilis test or for syphilis treatment, that someone can get a $10 incentive to help bring people in. And then lastly, I think is that some other community health professionals and public health nurses have been doing a lot of rapid and point of care testing in the community. This is just one of the tests. It's a dual rapid HIV and syphilis test. And it's really doing a lot, yes, to test, but also sometimes treatment can be out in the field with them. The CHPs don't do it, but maybe there's a public health nurse or a pharmacist that goes out with them. And also having these events begins conversations, it educates, it reduces stigma, and brings things to the community, like brings to the community where they are. So there's one place in Montana that does testing events in the park where people who are unhoused hang out. And so that's what they do. That's what they do there. So like, I like to always bring it back to Tiffany, and just consider with like all of this, all the different ways in which Tiffany's story could have been different if these, whether you call them safety nets or whether you call them, you know, wraparound care, community driven care would have been set up. Tiffany's story could have been way different. And, you know, I think it's a good goal to have to make sure that everybody's coming into our clinics, everybody in our community has access to the best care and the most love when they're coming into our clinics. That's all I have.